part of pathology, the last part mostly. So let us see the hallmarks of cancer. So cancer is mainly caused, it causes DNA mutations, which affects the cell processes like growth of the cell, DNA repair of the cell, and its survival also. So the main thing is growth signal self-sufficiency. To understand this, you need to understand different types of cells. First is proto-oncogene and tumor suppressor gene, which are very important in cancer. Proto-oncogene means it's a normal gene, but this proto-oncogene, if it converts into oncogene, then it has a chance to produce cancer. And next there is another gene called tumor suppressor gene. Actually, it suppresses a tumor. It's just like a car. In car, the accelerator is the proto-oncogene and the brake is a tumor suppressor gene. So if the brake goes away and if the car is only on, the oncogenes are more and the tumor suppressor genes are less, then that will cause a cancer. Okay, so first the proto-oncogene is a growth factor. uh, First we need to understand one model, or that is, this is a ligand, okay, or a growth factor. It comes and binds to a receptor. Okay, this is a receptor. So after binding with this receptor, it gives some transmission, it gives some signals inside the cell, and it mainly signals towards the nucleus of the cell. And in the nucleus there are some transcription factors which get released, and finally the cell cycle will get regulated in this way. So if any of this kind of machine gets disturbed, then you will get cancer. For example, if the growth factor is excess, like proto-oncogenes growth factors are excess, then also it will give more signal, more transcription factor, more cells are produced, and that will lead to cancer. Example is PDGF in brain tumors, astrocytoma. Next is the receptors example HER2 receptor, otherwise you can take some other different receptors. So if the receptors are more, HER2 receptor is more in breast cancer, red kit, all these are receptors. If the receptors are more, you can understand more receptors, they'll receive more signals, and again more production of more number of cells. And one more thing is RAS protein, signaling proteins like RAS proteins. If the signaling is more, cell will produce more cells. And next, transcription factors inside the nucleus like MIC, which are more, again same, more cells. Cell cycle regulators, cyclin CDK, if anything gets disturbed, again producing more number of cells. So now let us move on to anti-growth signal insensitivity. That is mutation in tumor suppressor gene like retinoblastoma. In the name you can understand it is a tumor suppressing gene. So if this is reduced or if it got mutated, actually retinoblastoma controls the cell cycle from G1 to S phase. Like it will check out the DNA, any repaired damaged DNA, and then it will remove that. Like it will say them to go apoptosis, and only it will allow the good cells to move from G1 to S phase. So if something problem here, then there will be production of cancer. And very important is loss of E-cadherin. If there is no E-cadherin, the cells will be not bound to each other. They will be loosely segregated, and they will just can easily go out of the basement membrane and cause cancer. Next, evasion of apoptosis, like mutations in gene which regulate apoptosis. For example, if there's a mutation in BCL2, BCL2 is a watchman for our cytochrome C in the mitochondria for normal, normal apoptosis process. So if there is some defect in BCL2, then you may get follicular B cell lymphoma. Next, coming to limitless replicative potential. What is this? This is a reactivation of telomerase. You know what is telomerase? It's like a tail-like structure. It is generally present in every cell, but it gets cut away whenever there is any DNA processing or maintenance. But in cancer cells, special feature is telomerase will never cut. It will be long for long time, and so that the cell will not die and prevent chromosome shortening and cell aging. So if telomerase is more in cancer, that means that cancer will never die. Next, coming to sustained angiogenesis. Of course, now cancer want the blood, so it will produce the blood forming factors like VEGF and fibrogen growth factor, all this, and it will lead to production of more blood vessels so that it can get more blood to that tumor. Okay, so neoangiogenesis means formation of new blood vessels, or else it will recruit the blood vessels from bone marrow called vasculogenesis, and these vessels may either be weak, leaky, or dilated. Last effect, not last, still some more. Next effect is Warburg effect. This is Shifting of glucose metabolism from mitochondria towards glycolysis, because now this glycolysis gives lot of sugar to the cancer, I mean lot of carbon which is needed for the cancer. Okay, next coming to immune evasion in cancer. Normally cancer cells, what they do is they try to escape from immune system, so that even our immune system will not find out it, and it can prolong and stay in our body for longer time. So what they do is they just evade the immune system, and they mainly decrease MHC class 1 expression so that they can escape from T cells. And they also secrete immunosuppressive factors like TGF beta, and also they recruit the regulatory T cells to down-regulate immune system. Okay, and they also regulate some immune checkpoint molecules, we'll discuss it in next page, which inhibit the immune response. Next, coming to tissue invasion. In the name itself you can see invading the tissue, that is loss of E-cadherin. So you lose intercellular junction, metalloproteinase degrade, and you invade to basement membrane by laminin, fibronectin, and finally lead to vascular dissemination. Now coming to metastasis. Metastasis is where tumor cells or emboli mainly spread by lymph or blood. Mostly metastasis is because of lymph, okay? Only some cancer spread by blood, okay? So target organ is often encountered, and some cancers show organ tropism, like lung cancers commonly metastasize to adrenals. Like some organs show love towards some organ, and they will metastasis there, like lung cancers. Okay, they only go to adrenal gland always. Now let us discuss the concept of immune checkpoint interactions. So actually there are different immune checkpoints which are developed by cancer. You can see the signals which modulate T cell activation and function. They can actually decrease the immune response against tumor cells. So they are mainly targeted by several cancer immunotherapies. Example, you can see the interaction of PD-1 on T cells, PD-L1 here PD-L1 on tumor cells. Okay, PD-1 from T cell, PD-L1 is attached to the tumor cell. Okay, so T cell dysfunction exhaustion is inhibited by antibodies against PD-1 like semiplimab, nivolumab, premolumab, or PD-L1 is inhibited by azitolizumab, durvalumab, avelumab, all these maps. Okay, next CTLA4 on T cells outcompetes CD28 for B7 on APC, and loss of T cell co-stimulatory signal is inhibited by antibodies against CTLA4 called ipilimumab. Now coming to cancer epidemiology. So the most common skin cancer is basal cell cancer, followed by squamous, followed by melanoma. Now coming to cancer incidence and mortality. Incidence means it is coming without unknowingly. In males, prostate cancer, next lung, colon, rectum. In females, breast, lung, colon, rectum. In children, mostly they get leukemia, next central nervous system, and neuroblastoma. So lung cancer is incidence is decrease in males but not change in female. Cancer mortality, most common causing mortality cancer is lung, next prostate, next colon and rectum in male. In female, first lung, next breast, next colon and rectum. In children, first leukemia, next CNS, next neuroblastoma. Okay, cancer is the second leading cause of death in United States. The first one is heart disease. Now let us come to metastasis. The common metastasis points is lymphatics. Next comes blood. So to the blood, the cancers which go are mostly sarcoma, and there are 4 cancers which go by blood. That is follicular thyroid cancer, choriocarcinoma, renal cell carcinoma, and hepatocellular carcinoma. Now coming to site of metastasis. So primarily the tumor in the brain. The brain tumor is coming from the lung, from the breast, from the melanoma, from the colon, from the kidney. Okay, LBMCK. Lung, breast, melanoma, colon, kidney. 50% of the brain tumors are mainly from metastasis. Commonly, multiple well circumscribed tumors, gray, white. You can see that at gray and white junction. You can see. So in the brain, mostly they are coming from lungs. Next, liver. In the liver, You can see this diagram C and D. So in the liver, the cancers are mainly coming from colon, followed by stomach, followed by pancreas. Liver and lung are most common sites of metastasis after regional lymph node. Next, coming to bone. Okay, EF, G, you can see all the bone cancers are coming first from prostate, breast, and next from kidney, next from thyroid and lung. So painful bones kill the lungs. So there are different mnemonics. Lots of brain metastasis can kill. Sometimes penetrates liver. Painful bones kill the lungs. Okay. So if you see bone metastasis, especially this E and F, they are greater than primary bone tumors like multiple myeloma. This is prediction for axial skeleton. Bone metastasis may be either lytic, blastic or mixed. If it is lytic, it is seen in thyroid, kidney, non-small cell lung cancer. If it is blastic, seen in prostate, small cell lung cancer. If it is mixed, it is seen in breast cancer. Now coming to oncogenes. Oncogenes is gain of function mutation converts to proto-oncogene to oncogene, and that will lead to cancer, already said. Okay. So different genes are involved. The first one is ALK. ALK is receptor tyrosine kinase. It will cause lung adenocarcinoma. EGFR will cause lung adenocarcinoma. HER2 will cause breast and gastric carcinoma. RET will cause MEN2A, MEN2B, medullary papillary thyroid, pheochromocytoma. BCR-ABL will cause CML, ALL. JAK2 will cause myeloproliferative neoplasm. BRAF will cause melanoma, non-Hodgkin lymphoma, colorectal carcinoma, papillary thyroid carcinoma, hairy cell leukemia. BRAF. C KIT. If you eat Kit Kat, you'll get gastrointestinal stromal tumor. Mix, you have CMYC, NMYC, LMYC. CMYC for Burkitt, NMYC for neuroblastoma, LMYC for lung cancer. CRAS for colorectal, lung, pancreatic. BCL2 for follicular diffuse large B-cell lymphoma. Actually, this is not explanatory. You should learn it. If you learn it, you can be in this range of fastness. Next, coming to tumor suppressor gene. One thing you need to know, any kind of gene, if it is hit only on two sides, two hit hypothesis, only then you can get cancer. If it is only one hit, you can't get cancer. Okay, but in germline mutations, already it is one side hit, other side it should be hit, then only you can get cancer. So APC mutation, colorectal cancer, BRCA1, BRCA2, breast, ovarian, prostate cancer, CDKN2A, many cancers. DCC colorectal, SMAD4 pancreatic colorectal, MEN1 multiple endocrine neoplasia 1, NF1 neurofibromatosis 1, NF2 neurofibromatosis 2, P10 prostate, breast, endometrial cancers, RB1 retinoblastoma and osteosarcoma, TP53 SBLA that is Lee-Fraumeni sarcoma, breast, brain, lung, leukemia, adrenal, TSC1 tuberous sclerosis, TSC2 tuberous sclerosis 2, VHL von Hippel-Lindau, WT1 Wills tumor. Now coming to carcinogens. Aflatoxins actually you get from aspergillus, mainly the farmer who have left his grains. In that grains you get the hepatocellular carcinoma because of that. Alkylating agents actually give chemotherapy drugs to the people, but because of drugs they are getting blood cancer, leukemia, lymphoma. Next, aromatic amines. In textile industries they mainly affect the bladder, you get transitional cell carcinoma. Next, coming to arsenic. Arsenic is mainly the people who work in dark in high sun areas, they feel their skin is dark, so they apply arsenic cream, so they get squamous cell carcinoma. Also they get lung cancer and hepatic angiosarcoma. Asbestos, like workers who work near asbestos, their lungs get affected, mainly bronchogenic carcinoma, mesothelioma. Tobacco smoke, because of smoking your bladder will get smoked, your cervix, your esophagus got smoked, like you get transitional cell carcinoma, squamous cell carcinoma, adenocarcinoma, renal cell carcinoma, squamous cell, all these types. Okay. It may affect pancreas, everything. Ethanol will affect esophagus, liver and breast. Ionizing radiation will affect blood and thyroid. Nickel, chromium, all this affect lung. Nitrosamine, smoked food, especially in China and Japan, they get stomach cancers. Radon, because of radon, which is lung cancer. Okay. Finally, vinyl chloride, which is in PVC pipes, it will affect your liver. So it's like more of reading, right? But it's good to listen if you know already all this. Epstein-Barr virus causes Burkitt lymphoma, Hodgkin lymphoma, CNS lymphoma, Of course, hepatitis B, hepatitis C cause hepatocellular carcinoma, HHV8 cause soy sarcoma, HPV human papilloma, it will cause cervical, penile, all, genital region cancer and also neck cancer. H. pylori, gastric cancer, malt, HTLV, TB. In TB, you can see T cell, leukemia, lymphoma, liver fluke, of course, cholangiocarcinoma, cystosoma, hematobiome, squamous cell bladder cancer. So no, we need to see tumor markers because in the blood we check for that and we can find out, yeah, this tumor marker is for this tumor. Okay, so what are the different tumor markers? Now let us check out them. If you see alkaline phosphatase in the blood as a tumor marker, then you should doubt for either bone or liver metastasis or Paget disease or seminoma. Okay, if you see alpha fetoprotein, then you should doubt for hepatocellular carcinoma, endodermal sinus tumor, or mixed germ cell tumor. Okay, and if you doubt for HCG, you should see hydatidiform moles, choriocarcinoma, gestational trophoblastic disease. If you say CA15-3, CA27-29, breast cancer, CA19-9, pancreatic adenocarcinoma, CA125, epithelial ovarian cancer, calcitonin in medullary thyroid cancer, CA in colorectal cancer, chromogranin in neuroendocrine tumors, LDH in testicular germ cells, neuron specific enolase in neuroendocrine tumors, PSA in prostate cancer. Now coming to important immunohistochemical stains. So you use chromogranin synaptophysin in neuroendocrine cells, cytokeratin epithelial cell, desmin muscle, GFAP, neuroglia, neurofilament neurons, PSA prostatic epithelium, S100 neural crest cells, melanoma, TRAP you see in tartrate resistant acid phosphatase we maintain in mesenchymal tissue. Of course they appear harder, but just make mnemonics or else you can just mug up them. Now coming to P glycoprotein, it is ATP dependent pump, also called multi-drug resistant protein. It is seen in adrenocortical carcinoma but also by other cancer cells. It is mainly used to pump out toxins including chemotherapic agents out of body. Like summoma body, you can see there like summoma is only the mnemonic, P for papillary carcinoma of thyroid. It is seen in that, and S for somatostatinoma, A for adrenals, M for meningioma, another M for malignant mesothelioma, O for ovarian serous carcinoma, P for prolactinoma, S for serous endometrial carcinoma. What is cachexia? It's weight loss and muscle atrophy and fatigue that is mainly because of some chronic diseases, and it is mediated by TNF alpha, gamma, interleukin 1 and interleukin 6. Coming to paraneoplastic syndromes. So here there are different types like musculoskeletal cutaneous, endocrine, hematological, neuromuscular. First one is musculocutaneous and skeletal, that is dermatomyositis. In the name you can see derma, skin is involved, muscle is involved. So this is a proximal muscle weakness and there are Gottron papules and heliotrope rash. Of course skin is involved and muscle weakness. Okay, so here you get adenocarcinoma, especially ovarian. Next, acanthosis nigricans, it is hyperpigmented skin in axilla and neck. Okay, it is associated with gastric adenocarcinoma and some other visceral malignancies. Next, sign of lesser teralt, it is seen in onset of multiple seborrheic keratosis. It is also associated with GI adenocarcinoma and some other visceral malignancy. Next, coming to hypertrophic osteoarthropathy, it is abnormal proliferation of skin and bone at distal extremities. Okay, so osteoarthropathy, clubbing, arthalgia, joint effusion, periosteosis of tubular bone. It is seen in association with adenocarcinoma of lung. Now coming to endocrine. In endocrine you have hypercalcemia, that is PTHRP, where it is squamous cell carcinoma of lung, head, neck, renal, bladder, breast, ovarian. Here there is increased 125 hydroxyvitamin D3 that is causing lymphoma. In Cushing syndrome there is more ACTH. In hyponatremia SIADH there is increased ADH causing small cell lung cancer. Now hematological polycythemia, more erythropoietin, paraneoplastic rise to high hematocrit. It is seen with pheochromocytoma, renal cell carcinoma, hemangioblastoma, leiomyoma. Pure red cell aplasia, anemia with low reticulocytes, good syndrome, hypogammaglobulinemia, thymoma, Trousseau syndrome, migratory superficial thrombophlebitis, non-bacterial endocarditis, deposition of sterile platelet thrombi on heart walls, adenocarcinoma, especially pancreatic. Now coming to neuromuscular, anti-NMDA receptor encephalitis, psychiatric disturbance, memory deficit, seizures, dyskinesia, autonomic instability, language dysfunction associated with ovarian teratoma. Opsclonus, myoclonus, ataxia syndrome, dancing eyes, dancing feet, neuroblastoma in children, small cell lung cancer in adults. Paraneoplastic cerebellar degeneration, antibodies against antigens in Purkinje cells, associated with small cell lung cancer, anti-WHO, gynecological breast cancers, anti-EO, Hodgkin lymphoma, anti-TIR. Paraneoplastic encephalomyelitis, antibodies against WHO antigens in neurons, Lambert-Eaton myasthenic syndrome, antibodies against presynaptic calcium channels, small cell lung cancer, myasthenia gravis, antibodies against postsynaptic ACH receptors, thymoma. Now finally coming to aging. Normal aging is where time organ function resulting increased susceptibility differs. Of course, it is associated with genetic, that is telomere shortening, epigenetic, that is DNA will get methylated, and metabolic, mitochondria will get dysfunction. So three things: telomere shortening, DNA methylation, mitochondrial dysfunction. So in cardiovascular you will see decrease arterial compliance, means all the blood vessels. So aging, like in elderly people, if you see, they'll have more hypertension because their blood vessels are stiffened, more aortic diameter, and decreased left ventricular size because of myocardial hypertrophy and increase in left atrial cavity size. There will be also aortic and mitral valve calcification and decreased heart rate. In gastrointestinal, you will see decreased lower esophageal tone, decreased mucosal protection, decreased colonic motility. So in aging, all body cells are affected. Blood cells are affected because there is low bone marrow and increased marrow fat, less response to stress. And in immunity, predominant effect on adaptive immunity. There are decreased B and T cells, okay. And there's also immunosenescence, which impairs response to new antigens. In musculoskeletal, there is decreased muscle mass, decreased bone mass, and joint cartilage thinning. In nerves, there is decreased bone volume, cerebral blood flow is decreased, okay. And special senses, accommodation, presbyopia, you get decreased hearing, decreased smell taste. So you can remember aging like all old people features. In skin, decrease collagen, decrease elastin, decrease sweat gland, sebaceous gland. Intrinsic aging will be decreased capacity of dermal fibroblasts. Extrinsic aging will be degradation of dermal collagen, elastin. And in renal, decrease GFR, decrease RBF, voiding. So everything is like almost decreased in aging. In reproductive, males will get testicular atrophy, prostate enlargement, lower ejaculation, ejaculation, decreased libido. Females will have vulvovaginal atrophy, vaginal shortening, thinning, dryness. Respiratory final, increase lung compliance, decrease chest wall compliance, decrease respiratory muscle, increase A gradient, increase V/Q mismatch, ventilatory response to hypoxia, hypercapnia is blunted, less cough, slower mucociliary clearance. So by this we have completed pathology. Like here we see more of remembering memory type of things, right? Not like explanatory type. Only the starting path was explanatory. So don't think otherwise for this video if it's lot of memory type, okay? So it's done.